If your practice is like mine, you're watching patients pretty closely, you're watching markers, you're doing scans every now and then, and eventually 6-8 months into first-line therapy, almost everybody's cancer will start to grow. And so we're looking for this, and we find it. So when patients progress, we have now a bunch of second-line choices. Now, if you started with Gem-Abraxane or Gem-Nab-Paclitaxel in frontline, the way I think about it is I want to go to fluoropyrimidine-based therapy second line. And we know we've got fluoropyrimidine with liposomal irinotecan, approved second-line regimen. We've got conflicting data with fluoropyrimidine oxaliplatin. We've got one positive clinical trial, one negative clinical trial. And so I've actually shifted some of my enthusiasm from everybody's got to get a little FOLFOX to everybody's got to get a little FOLFIRI, and using more irinotecan-based. But you can do it. There are trials that show you can do it. You can give FOLFIRINOX in the second line if you've done a good job of managing that first-line patient and maintaining their performance status. But you just have to recognize that that patient's a little more beat up, a little more myelosuppressed. No one gives FOLFIRINOX full dose. No one does. We all drop the bolus. We all modify the doses of irinotecan, et cetera. So the on-label regimens for FOLFIRINOX are not used practically. So when you come to second line, you also have to be aware of that and do modify your doses and watch your patient closely. I've got a patient right now who's getting second line FOLFIRINOX after a front-line Gem-Nab-Paclitaxel. She did very poorly after 4 cycles, but her cancer responded very nicely. So we've essentially gotten her cancer back off and now resting her with a kind of maintenance approach in the second line. In colon cancer, in my world and many other cancers, we right from the beginning think about all the different treatments we're going to give this patient. And we're even telling patients that you're going to get all these drugs and it's just we're going to play a long chess game and we're going to move them here and there. In pancreas cancer, this is sort of a new idea for us because our concept with these patients is just keep you alive, get you off the ledge as fast as we can and try and keep you there and kind of hold on. Well, now we can actually think about lines of therapy in sequence because more and more patients are benefiting from front line and second line. We have more and more tools. And so at least in some patients, particularly our case, low tumor burden, going to be around through second line therapy. This is a patient where you think about sequential therapy right from the beginning. And so that does influence our decision making. And the way I think about it is you want to play a gem-based regimen and you want to play a fluoropyrimidine-based regimen in that patient. And you want to make sure you get both of them in at some point along the way. And beyond when and how, I sort of leave that up to the doc, the situation, the patient in front of you. But part of our challenge is to try and get both of those in so we can get the best survival. This patient's had Gem-Nab-Paclitaxel. She's now had FOLFIRINOX and has progression of disease. And what next? Well, first, is she a candidate for more treatment? At this point, it's unusual to see somebody doing well, but that happens. It does happen. The reality is we don't have anything routine or standard to give her at this point. Having had FOLFIRINOX, I wouldn't then try the liposomal irinotecan compound in third line. I don't think that's likely to work any better necessarily than your FOLFIRINOX and has some toxicity, so I probably wouldn't go there. In our shop, this patient would probably go on to clinical trials. We are looking at more and more new therapies in this space. So if a patient has a good performance status, doing okay, what I would recommend is doing a new biopsy on that patient, sending that biopsy for broad molecular profile and see if that patient is eligible for anything in the NCI Match clinical trial or the ASCO Taper clinical trial or other studies that are out there.